Hi everybody. Sorry we're late today. Some heavy healing in process there, so we're running a little late. So welcome back to another Friday Facebook Live. Today we've got Val.
Hi,
Val's
guys.
joined the crew. We're going to talk to you guys today about some shoulder impingement. So I guess first off, we have to explain what is shoulder impingement.
Or what is the shoulder, right?
What is the shoulder? How do you spell shoulder?
So basically, yeah, our shoulder is a joint, right? There's a couple of bones that have to do with the shoulder.
Just a couple.
Just a couple. So we have our collarbone, we have our shoulder blade, and we have our humerus, which is our arm bone. And then, it ties up to our sternum, and our shoulder blade works on our ribs on the back part. So there's very little bone to bone. It's actually, there's just like a little structure on the side part of our shoulder blade that articulates with our arm bone, so our humerus, right? So in order to build a lot of stability, there's different structures like capsules, ligaments, tendons, even bursas, which is basically little balloons of fluid
pouches. Absolutely.
That allow better movement in our shoulder.
Yeah, essentially it's a very shallow joint, like Val was saying, with a big ball in the end. So our shoulders are like our hips. We call them a ball and socket joint. So they can kind of move in many different planes.
Yeah, which is why we're able to move in 180 degrees in two different planes.
And why they get injured all the time.
Yes.
So essentially it sacrifices stability for mobility. So it relies on this capsule, primarily to help hold the arm bone in. So that leads us to impingement. So impingement is essentially when you pinch, usually the rotator cuff tendon in certain motions like abduction, when you lift your arm out to the side, what can happen is that the tendon, typically the supraspinatus, so the rotator cuff, one of the four rotator cuff muscles, gets pinched underneath what's called your acromion process.
Which is basically like a little hook on the top part of your shoulder blade. So when you lift up your arm, that bone puts pressure on we have a little bit of a picture here, right? So the acromion is this bone over here. Sorry, I'm blocking your face. The acromion is this bone. So as you lift your arm towards the side, your structures get pinched and create either irritation, pain,
inflammation.
Yes.
Yeah, definitely just hurts.
Yeah, it's really not comfortable. And actually, if you let it go untreated, a lot of terrible things can happen, such as tendinitises, calcifications, tears even, and thickening of the tendon, which actually makes it difficult in the long run, because if there's thickening of the tendon and you already have a very small area for your tendon to move, it makes rehab actually quite difficult, and
that's like the biggest compounding factor, is that you've got a small little space to begin with, and once you get an impingement syndrome to occur, that's what happens. It just gets there's less space. Now you get a thick, swollen tendon with less room to be in, and then that's why the exercises that we're going to talk about later are a big way to kind of help relieve the stress on that tendon.
Yeah.
So essentially, we have to answer the question: is how does it occur? So you can kind of get it both ways, right? You can get like a one big accident, like a fall on an arm like this, where you'd land and you'd like jam it up and compress the tendon. So we'll call it a macro trauma. Or you can have that kind of repetitive kind of micro trauma event. So I always kind of think of people that maybe, let's say like an electrician, for instance, someone who's like typically working with their arms above their heads for extended periods of time.
Yeah.
So I laugh
even like different sports too, right?
Sports too, absolutely. Anything that's you're either lifting your arm up to your sides or even more so above 90 degrees. That's the kind of the biggest demographic. I always laugh. I have some kids in here that say, I'm going to look at getting into electrician school, and I always tell them, I think you should go for an x-ray first. What are you talking about? Why do you go for an x-ray? So the one unlucky thing for people that get some shoulder impingement is that acromion process that Val was talking about, that little lip that comes off the shoulder blade, actually has they categorize them three different ways. They call it a type 1, a type 2, or a type 3 acromion. And if you're lucky, you've got a type 1, which is relatively flat. There's not a big curve on it. But by the time you get to type 3, there's quite
curve like that?
Quite a little curve on it, which makes you really, really susceptible to injury, which makes it much more susceptible to impingement syndrome. And in fact, for someone who's got it chronically and has leaves work, goes for passive rehabilitation, like seeing someone like us, and it still doesn't respond, typically they have to go in for surgery, right? It's called a Neer's acromioplasty. Some guy Neer invented this surgery where they go in, they repair the tendon, But what they do is they actually shave the acromion process down, and they take the hook off of it to make it more of a straight edge. Anyway, so all that to say, go back to macro trauma where there's a fall on it, a compression injury, where you pinch the tendon underneath the acromion, the inflammatory process begins, and pain and swelling and inflammation.
All the things you don't want.
Yeah, a lack of range of motion usually, where you start to get limited in abduction, which is the movement kind of
the side
up to
movement,
the side, and usually quite the significant lack of strength in certain ranges of motion.
Yeah, and they can also happen with people who just have instabilities in their shoulder, or people who have poor shoulder posture or biomechanics, which is just another word to say the way it works. And we see that a lot with people who are at their desks all day. And if, let's say, for a reason they had to lift their arm up a lot over the weekend or whatnot, that can also create irritation as well. So just doing overhand movements, you don't necessarily need to do it on day to day, but just overhand movements in a poor way of doing it, that also can create issues.
That's it. I mean, like Val said, you sit at a desk all day, and you're 40 hours in a desk and your posture's not good, and this is part of the exercises we'll talk about later, when you've kind of grown into that position. So as we're living day by day, we're constantly remodeling the bony tissue in our body. We're breaking down old bone, laying down new bone, and the same thing with the muscles. So if we're sitting at a computer all day and our posture's not great, and we get that rounded shoulder, which we talked about earlier, when we round our shoulder forward, we're minimizing what's called the subacromial space where these tendons pass through, which makes us more prone to rotator cuff injuries or inflammation, and then impingement syndrome. And so you have that forward head position, the rounded shoulders. We're really kind of setting the parameters where you can get this impingement syndrome. So then you go out and say, okay, well, I'm putting up my Christmas lights this year, right? And you go and use your arms, but you don't have the thoracic mobility and the mobility of all these structures that you need. And yes, that's when you develop.
Yeah, it happened to me over the holidays, just putting lights on the tree. So.
Nice. So what are the main symptoms we should talk about? What do you think?
Pain.
Pain. Where's the pain? Where do you think
in the arm, in the shoulder? But sometimes we have even pain down the arm, what we call referred pain. So often people come in and have pain down the arm, and actually the pain stemming directly from the shoulder.
Classic.
So so that stream or that line of pain that we have down the arm. Just having a hard time lifting your arm up. So sometimes the pain's okay, depending on where your dysfunction is. So let's say if it's always inflammatory, you can have constant pain, versus if it's more mechanical, so you don't have pain at rest, but if you lift your arm up, as soon as you get into the range of 90 degrees, what we call, right? So over the shoulder kind of range, that can start really pinching that area and creating pain purely just with movement.
Yes.
Other than that, I mean, you can have other
it's mostly pain, like you said, pain and like Val said, even though the origins, they come in with the attachment and the supraspinatus and such, it's usually this like ache, this deep, like dull ache in the back, or the deltoid insertion, like in the upper lateral arm. So,
which means upper outside arm.
Sorry, that's it. So usually then people then complain, like Val said, 90 degrees, are using it, and a lot of times it's at night, right? So our body we're during the day, and if it's not one of those ones that's chronically sore all the time, then when we go to lay down at night and our body's trying to shut down and go to sleep, and we're a side sleeper, and we lay on that side and that cups our shoulder forward, then they get this gnawing pain at night. And then conversely, sometimes they flip to the opposite side, and the same thing happens. The way their arm lays down in front of them, they get that same pain. So that's usually a pretty classic sign too of some impingement stuff.
So if that's the case, there are tests. But if that's the case, you can always, I mean, I've thought with my clients it's helped sleeping with a body pillow, so not allowing that arm to fall forward, allowing the arms to, the shoulder to stay straight. That always helps. Yeah.
So how do we treat it? So a few things. We have to test and assess it to see what we're dealing with. So usually the classic test for impingement is you would have someone bring their arm out in front of them, out to the side a bit, and you get them to internally rotate their arm. And as we push down on their arm and they resist, if that tendon is impinged, then typically that's one of the telltale signs that they've got some sort of impingement syndrome. As
also, like any sort of rotation, like Jay mentioned, across the body kind of tests, just anything to make the space smaller, to compromise that space. And obviously if that creates any kind of pain, the space is already compromised.
Exactly. So treatment options, few. So usually here at Vitality Therapy we do manual therapy skills. So we do a lot of mobilization. So like Val said earlier, the shoulder's a pretty complex joint. And we're not necessarily always starting at the shoulder itself. We've got to make sure that the sternum and the rib cage and the thoracic spine, all those areas have to be mobile. We can't get full shoulder mobility if we don't have thoracic extension and good thoracic mobility.
Yeah.
So,
I mean, you guys can even try the test out at home. If you guys were to fully slump and try to lift your arm up, you can't. You can't lift it up. Versus if you open up, you bring your chest out. I mean, you can get full range.
Absolutely. So we do manual therapy stuff, mobilizations of the rib cage, the shoulder blade, clavicle, and then we do a lot of times we'll challenge the capsule itself because as people. Most people come in with a micro trauma, let's say, or the desk workers that have that forward positioning, so then we have to stretch the capsule, the glenohumeral capsule.
The capsule's like the envelope around the joint.
Around the
so
joint.
It's just,
so as someone sits all day, they can see my shoulders and they round forward. What happens is the humerus ends up being too far forward in its socket. So they get tension in the posterior aspect and the inferior aspect of the capsule. So our job is usually to mobilize to increase the posterior aspect of that humerus and inferior to allow the shoulders to sit properly and not be rounded. Again, when we're rounded and our head's forward, we're compromising that space. So we've got to work on essentially usually stretching the front and mobilizing the back and strengthening the back to get people used to
being comfortable in that position, because that's another thing. A lot of people aren't comfortable in what we call like an optimal seated position, right?
Exactly. So that's the biggest way to treat it. And obviously then, depending on the stage of the injury at the start, there's a lot of rest and avoiding certain activities and icing to help bring down some inflammation. Sometimes we refer to the doctor if it's quite bad, if it's enough that they're not sleeping at night, perhaps their doctor can help them out in other avenues. So essentially then we'd like to go, once the pain subsides and you put the fire out, if you will, then so we're doing stretching and postural stuff to help that out, and then followed by some strengthening stuff. So early on, we're looking at stuff. So what kind of stuff can we do, or can someone do at home to help? Well, it's a lot of postural stuff, right? So it's a lot of what we do, these chin tucks to help get our head more over our shoulders and not in front. We get a lot of these ones at the desk where people would sit and they'd roll their shoulder blades back and together. We call it scapular setting, where they're squeezing their shoulder blades together and they're helping to reset the position of the shoulder joint itself.
And bringing your chest forward too, making sure you have good thoracic extension or getting out of thoracic flexion.
Exactly.
So meaning the bending motion, you want to get out of that.
And then at the same time, we're trying to educate the patient, saying, okay, these are some things you should be doing, but then conversely, there's some things that you can't do, or you should be avoiding, right? And that's what we talked about earlier, where you're doing repetitive motions above your head. When someone's got an acute flare-up, we're always saying, okay, well, you're trying to delegate some responsibilities at home if you can. You don't want to be changing the light bulbs. You don't want to be raking the leaves, and that's your upper arm, and you keep jamming that shoulder back.
Or shoveling the snow.
That's a good one too. So all that kind of stuff is what you need to kind of subside for a while to let that inflammation come down.
And I find it's really great to be aware of your posture as often as possible. So if you need to put yourself some reminders or whatnot, changing your posture day to day is what's going to make the biggest difference. So, of course, doing exercises, a couple of times throughout your day, which takes
3 minutes.
A couple of times it has a good impact, but what's going to make the biggest difference is about you being aware of the way you're holding yourself and just correcting yourself throughout the day. I think that's the biggest chunk.
Absolutely. That's if you're spending 8 hours in front of a desk and you're doing 4.5 minutes of exercise at home, that's not an ideal ratio for sure. So that's sometimes you have to look at your desk setup if you are in front of a computer and just have very easily have a colleague look and say, okay, my eyes hitting roughly this part of the screen. How do I look that way? It's all about being aware of your posture, like Val said, and making that conscientious effort to make that change. And no one's perfect, right? Like I do every day. I sit, I'm treating, I'm concentrating. I'm like, oh, I better sit taller.
Yeah.
Like 10 seconds later, I'm doing it again.
Yeah.
But if I never had that correction, if I never had that awareness, then you'd always be in that position.
Yeah.
So some people never get in the right position.
Right. And if you don't get out of that position, then your muscles, they can shorten and other muscles can lengthen, right? And then that's when it makes it way more difficult to change that position and to hold it. So hence, making that change as soon as possible makes all of a difference.
Exactly.
Yeah.
All right, anything else? What do you think people, that's it. And then afterwards, I guess when the inflammation comes down, then you want to kind of maybe do some more strengthening, right? That's when we talk about we'll strengthen the back, because typically if you are, let's say the micro person where you're at a desk all the time, like Val said, these get short and relatively tight compared to the back, so we usually try to do some strengthening of the upper back. And then, if it needs it, we'll do some strengthening specifically of the rotator cuff itself, right? But not early in the process, because that's just going to flare things up more than anything.
Yeah.
So that's it. That's shoulder impingement as a wrap. I mean,
hope you guys enjoyed it.
Exactly. Take care, guys. We'll see you next Friday. All the best. Enjoy your weekend.
Bye.